Good afternoon. It's a beautiful sunny day here in Washington, D.C. A great day for our webinar this afternoon, Perspectives on Medication Adherence and Safety. There are still people, I see the numbers going up, dialing in and getting online. So we'll get started in just about 1 minute. We've got a great update for everyone today and some really exciting material to share with everyone. So I'm delighted that you could join us here today. And Claudia, are we ready to go?
We're ready to go.
Okay, great. So we're going to be talking today about the initiative, Electronic Medication Adherence Initiative. I'm going to give a little bit of an overview about what that collaborative is. And then we're going to hear from 3 individuals who have been a part of the work that we've been doing over the last year. Rick Ratliff, who's President and Chief Commercial Officer of ConnectiveRX. Tim Arnold with Cerner Corporation, the Senior Strategist and Advocate Cerner Collaborative. And Mike Fitzgibbons, Vice President of Pharmacy Stars at UnitedHealthcare, Medicare, and Retirement. And then we'll get to some Q&A through the chat box if folks have questions. Next slide. And there's a wonderful picture of our 3 speakers here today. Aren't we lucky to have them? Wow. All right, next slide here. If you have questions today, you're all muted, so we can't hear you talking right now. But if you have any technical difficulties, please jump into the chat box there, and we'll get back to you as soon as possible. For questions later on, we're going to go through the Q&A feature, the chat feature, as I just mentioned. And I want to encourage you right now to jump on our resource center at www.ehidc.org/resources, and you can see a couple of different things. The slides from today's webinar up there, and you will also see an eMAC update, which is about supporting compliance in medication adherence. And those are 2 documents that I think you'll find very useful both for this event today and also. And we encourage you to download those, share them as much as you'd like, quote from them, credit them, whatever you'd like to do. This is really important work to us, and we want to make sure that it's spread throughout the industry. All right, so for those of you who aren't familiar with the eHealth Initiative, our mission is to serve as the industry leader convening executives from across the spectrum of healthcare. We bring all the best folks together and try to identify best practices and then share them. So we're really about identifying best practices and disseminating them broadly. We want to find out what works and help other people learn about what works. Next slide. This is just a sampling of some of the different folks that are members of eHealth Initiative, and I'll give you a slide in just a moment so you can see some of the different organizations who have been involved with this particular initiative. This is just one initiative that eHealth Initiative and our foundation are working on currently, but we work on a broad range of things. Next slide, Claudia. Everything that we do, we're a nonprofit, and everything that we do is really mission driven. And what we're trying to do, as I mentioned, is identify best practices and help executives across the spectrum of healthcare learn about those. So everything's really centered around our eHealth Resource Center, which you can see at ehidc.org/resources. And again, that's where you'll find the slides from today, and you will also find the report we're going to be talking a little bit about today. But this is where all of our work goes. The Resource Center includes hundreds and hundreds of papers, reports, surveys, infographics, all different expert interviews, videos. We'll be loading some podcasts up there in the next week or so. It's a really great resource. The best thing about the eHealth Resource Center is that every single one of you has the opportunity and ability to upload your own documents, your own stories, and your own best practices, and we encourage you to do that. If you have a report or a case study that your organization has done or want to share something that you've done, please go to the Resource Center and you can upload it. All you got to do is tell us which section you want it to be displayed in, and we'll go ahead and do that for you. So I encourage you, don't just go there to download things, but go there to upload things for us so others can see what you're doing. Next slide. This is just a sampling of some of the different areas that we're working in right now: value and reimbursement, technology and analytics, and workflow and patient experience. We just had a wonderful series of executive roundtables in DC about 10 days ago here in Washington, looking at these areas. And you're going to hear more about these areas over the next coming weeks and months as you see different pilot projects roll out and different reports and research and webinars. Next slide. And one more thing, we like to have a good party. So we are inviting all of you, if you're interested. We'll be having a reception at HIMSS for those of you who will be at HIMSS. We invite members and non-members alike to join us Tuesday, March 8th at 6:30 to 7:30. We're going to be right actually inside the convention center there, and you can see more information on our website at ehidc.org. We'd love for you to come. Just go ahead and register for us so we know to expect you. And we want to thank our wonderful supporters, Cerner, ConnectiveRX, and UnitedHealthcare. This initiative that we're going to be talking about today is really a broad, very broad, extended initiative that we've been working on over the last year and will continue to work on. And as I mentioned earlier, we are a small nonprofit, and we can't do the things we do without the generous support of organizations like Cerner, UnitedHealthcare, and ConnectiveRX. So we're really grateful for their support and that they also see the importance of this type of program and collaborative. Next slide. So, Electronic Medication Adherence Collaborative. For short, we call it eMAC. eMAC was devised about a year ago, and what it really was a number of different organizations who came together and realized that, you know, medication adherence is a huge problem. Solving this has always been something that's perplexed people, and we've talked about for years and years and years. And currently, a lot of the initiatives and solutions looking at medication adherence are very siloed. So pharmacies have specific solutions, doctors' offices have solutions, pharmaceutical manufacturers might have ideas about how to do things, your specific doctor might have a way to do it, your health plan might recommend different ways for you to take your medicine. And all of these siloed efforts are really disjointed. And we said, well, hey, wouldn't it be great if we could have a multidisciplinary approach and figure out how do we bring these different solutions together? How do we leverage the work that each other are doing and try to look at this in a fresh way and determine what kind of data can we share with each other and try to take a fresh look at medication adherence. So we decided that we really wanted to have a forum for companies to share information about what was going on and coordinate across the spectrum. Next slide. There we go. This is a list of the different organizations who have been participating over the last year. You can see it's a really diverse group of folks. We've had a couple of in-person meetings, and we've had a virtual meeting as well, and we'll be having another meeting in the next couple of months to continue our work. But really a broad range of folks, nonprofits, for-profits, payers, providers, pharmaceutical companies, and a number of different researchers, policymakers and associations have been involved, because as you know, there's been a lot of work in this area, and there's a lot to share and much that we can do to work together and collaborate. Next slide.
Having a little technical difficulty, Jen. We'll get to it right away.
Okay, great. There we go. So we launched in 2017 this multi-stakeholder collaborative, which I just said here, and we really wanted to figure out, again, a forum for people to work together. Go to the next slide there. I think we're just about ready to turn this over to Rick. The charter of the group, and I think Rick's going to talk about this a little bit, was really to share best practices, talk about the effectiveness of different programs, and then disseminate this information broadly. Next slide, Claudia. Okay, one thing to note, you know, there are a lot of different ways that solutions have tackled medication adherence, and we recognize that there are a lot of reasons people don't take their medication. Some are behavioral, so that there are certainly behavioral approaches and things and programs that we can do to focus on helping people take their medicine? Is it a motivational issue? What are kind of the barriers that patients face in terms of taking their medicine or not taking their medicine or not wanting to take their medicine? So there are all sorts of things we need to understand about that. A lot of the approaches that we've learned about and researched are analytic approaches, and you're going to hear today from Cerner, who's got a really interesting approach in terms of tackling medication adherence as well. So that's another area of focus that the eMAC has been looking at. Next slide. Okay, and I want to turn it over to Rick Ratliff, who is the President and Chief Commercial Officer of ConnectiveRX. Rick is a member of our board of directors and graciously agreed to chair this work over the last year and has really done an incredible job of leading this. He's, as many of you know, really, I think one of the probably most influential folks around pharmaceuticals and pharmacy and pushing the edge in terms of this area. And we were just delighted to have him help lead this effort. So I'm going to turn it over to Rick, who's going to make a few comments.
All right. Thanks, Jen. Can you hear me okay?
Yeah, perfect.
Yeah. Okay. Yeah. So I just want to make a few introductory comments so that we can leave enough time for our speakers this afternoon as well as questions and answers towards the end. So as Jen said on the front end, as we go through this and any questions come to mind, please write those down and then we'll look to answer as many as possible towards the end of the session. To kick off the eMAC program, we actually started off with a roundtable in September of last year and brought together over 20 representatives from across the industry, organizations such as NIH, University of Pennsylvania, Merck, a number of payers and other providers, to really enter into this conversation on medication adherence and drill into experiences that we've all had through our different initiatives over the last number of years. Because as Jen has said, this topic is not necessarily new, but we are at a different point in time, which offers us some interesting opportunities. So we spent some time with this group talking through, existing barriers to medication adherence, and looked at a number of different research initiatives and different programs that the representatives around the table had led over the last number of years to see what's working and what's not working out in the market. See if we can start to flesh out some industry best practices that we can pull together and bring to and learn from and bring to the broader market in some meaningful way. And the outcome of that session was to really start to tee up a concept of a medication adherence vital sign as a tool or a mechanism to ensure engagement in the conversation about medication adherence with the patient. Key point here is that while there's many things we can do with technology, and we'll talk about some of that today, a lot of this is behavioral oriented. And so we need to find that intersection of the behavioral aspects and the capabilities that technology can bring to the table that really help better predict issues with medication adherence and determination of the appropriate steps to take from an intervention perspective when it's appropriate. So the vital sign was really the key point coming out of that meeting. We'll spend a little more time talking about that this afternoon. So if we go to the next slide. So following the roundtable in September, we brought back a number of the individuals that were with us in that meeting in another roundtable that was held in the December timeframe. And then we complemented that with additional representatives from retail pharmacy, from the pharma industry, from government organizations, a number of different provider organizations, and again, payers and other stakeholders interested in this topic. One of the interesting topics that we kicked off that somewhat complements this idea of the vital sign was the thought of using a FICO score as a mechanism to help determine adherence or risk of adherence. And so Dr. Kristen Reichart from Johns Hopkins spent some time talking through some work that had been done to look at utilization of other industry type efforts to measure risk and applying that in healthcare, which is a very interesting conversation. Again, it comes back to this discussion around the vital sign. We continue to go back and revisit some of the barriers to adherence and dug in a little deeper into social and behavior determinants, and then had a significant discussion around data access, the ability to utilize data across different points of care in order to, again, help inform or predict adherence and opportunities to intervene and drive improved adherence, which brought us back towards the end to this discussion of the vital sign for medication adherence. Significant amount of discussion on that, and as Jen referenced on the front end, much of that discussion has been documented and is available to you in the eHealth Initiative Resource Center, so I'd encourage you to take a look at that as a reference document to dig into a little more detail on where we've been and to some extent where we're going. So with that kind of as a basis of where we've been, let's now kind of transition over to revisiting some of the opportunities within medication adherence. And then we'll start to transition from there into this discussion on the vital signs and actually looking at a real case study brought to us by Cerner. So I'm going to turn it over to Mike Fitzgibbons, who's joined us today from UnitedHealthcare's organization. So, Mike.
Thank you. Thank you very much. Appreciate that. Good afternoon. Mike Fitzgibbons with UnitedHealthcare Medicare and Retirement, and I'd like to kind of give a little backdrop as well. Within Medicare and Retirement, it's medication adherence is very important for our seniors. And within, the world I live in, the Centers of Medicare and Medicaid, has really put a very laser focus on medication adherence. And, there's many different reasons for that. And with that, organizations like UnitedHealthcare have really put forth a lot of energy and passion behind making sure that we've got a strong focus on medication adherence to drive that performance and help our members, our patients, to live healthier lives. And ultimately, it's really the patient that we put forth, even though we're all striving very hard to achieve star rating goals that CMS has put in front of us. The actual efforts that we're doing really is putting the patient right in the middle of things. And there's, like I said, lots of reasons for doing that. There are approximately about half the patients at some point are not taking their medications as prescribed, but there's about 30% of the population that essentially are chronic or need that laser focus. And by doing that and really focusing our energies on improving adherence of that population, we can reduce hospital stays, we can improve overall chronic condition of our patients, and that ultimately results in lower hospitalization and lower medical costs within the system. So I think overall it's kind of a win-win for the patient, for the plan, even for pharma too, for the medications that are delivered to our overall patients. Why don't we go to the next page, please? Let's move it to one more. There we go. As we work with our members, our patients within UnitedHealthcare, there are many different reasons for not taking medications, and not every one of our patients follows the same game plan. They all have individual, unique reasons. The number one barrier that we do see is forgetfulness. Health literacy in regards to understanding the importance of taking medications on a regular basis. is something that challenges our members as well. We do find that in some cases costs can be a burden, and making sure that our formularies are established that allow low-cost alternatives for our members is something that we look for helping our patients as well. But cost can continue to be an issue, and the nice thing is that there are many different alternatives for patients to help them, be it generics or through low-income subsidies from the government, things of that nature to help them as well. Side effects is also another impact as well, and identifying what those barriers are and looking at other alternatives that our patients can actually obtain through different medication therapies. That also is something that we seek to identify and work with our overall patients on that as well. Let's go to the last page. So how do we really work with our membership, with our patients, to drive adherence? Medication adherence is not a one and done activity. It's a very complicated process of really understanding, where the patient is throughout the year. Patients can have a varying level of types of refill patterns. They could have a 30-day prescription versus, longer extended day supply, like 90-day supply. And with that, there can be constant breakdowns of when the patient is obtaining their refill, and the refill really is the measurement of the overall adherence. So with that, we want to be able to reinforce the adherence activity of our patients by monitoring their overall performance, and it is a very complex process of doing that in regards to being able to calculate and monitor the overall performance of our membership, and identify those patients that essentially are lacking picking up their medications on time and following up with them to really keep them on track and going from there. We use a multitude of different channels, if you will, to address overall adherence. Physicians and caregivers, are very important in regards to being able to provide that line of engagement, frontline engagement with our patients. We also have pharmacists in regards to point of service. We even, look at having those point of service engagement activities and follow up from a pharmacist directly to a patient as well, to ensure that they, are taking their medications, addressing any side effect concerns, and as well as being kind of that liaison between the physician and the patient as well. And then health plan coordination, such as UnitedHealthcare and other plans like us. We work with the various physicians, caregivers, and pharmacists to make sure that there is a constant flow of information to really nudge each one of these channels along to bring to life, those patients that have deficiencies and really keep them on track. But overall, creating visibility to adherence is really key to driving timely local patient engagement. And as we've talked collectively, we see that there is definitely a need for a vital sign for adherence to really keep that front of mind so that each and every one of our patients can get that timely attention should they fall behind in taking their medications or picking up their medications on time and becoming non-adherent. And overall, by keeping them adherent, as I mentioned before, it has long-lasting health impacts and helps our patients live healthier lives, maintaining their adherence to their drug medication therapies. So with that, I'm going to hand the ball over and we'll continue the discussion about why the importance of a vital sign, and Tim Arnold will discuss that particular component.
Great. Thanks, Mike. Can everybody hear me okay?
Yeah, we can hear you.
Sounds good.
Awesome. Thank you for the feedback. Appreciate it. So as Mike mentioned, I'm Tim Arnold. I'm the manager of the Advocate Cerner Collaborative, which, as the name would indicate, is a collaborative between Advocate Healthcare, a large healthcare system based in the Chicago area, and Cerner, the healthcare IT company. And our team is a cross-functional, cross-organizational team. So we have employees from both Advocate and Cerner that are part of this. And broadly speaking, we use or seek to use data and technology to advance the broad objectives of population health. And medication adherence certainly fits into that. I'm going to talk a little bit about this notion. You've heard the foreshadowing throughout the presentation so far about this notion of med adherence as a vital sign. I'm going to dig into that, talk about the pros and cons, or I should say challenges to that, and then show you one example that might pique your interest. Next slide, please. So yeah, in reflecting on the notion of a vital sign, and I put vital sign in quotes here because when you think about the vital signs as we know them, like body temperature, pulse, blood pressure, those are immediate feedback indicators about vital functions of the body at a specific moment in time. And so we're taking some liberties here in terms of using the term vital sign, but thinking about it broadly, we might think about a vital sign as a key indicator of health, something that is measurable, something that's widely understood. So whether we're talking about providers in this part of the country or that part of the world, or at different levels, that when we talk about body temperature or pulse, most people know what we're talking about. Easily interpreted. In some cases, that might require some clinical background knowledge, but given a certain amount of basic knowledge, that most people can arrive at the same interpretations when presented with the same information. And that ultimately, these would be actionable. So if you have some information about something that it triggers some additional actions that might help to improve a patient's health. Next slide, please. So why should we make med adherence a vital sign, so to speak? Well, as both Rick and Mike talked about in their sections, and Jen talked about as well, poor medication adherence is well documented as a significant factor to poor health outcomes. So we know that this is a serious problem across the industry that's holding patients back from the best health outcomes. It is something that can be measured. I'm going to talk about that a little bit, and it is actionable. And Mike referenced that. I liked how he spelled out the multiple members of the care team who can take specific actions that help to address medication adherence. Next slide. Now, what are some of the challenges about making this a quote-unquote vital sign? Well, even though we can measure it, it's not easy to measure. And there are a number of objective ways of capturing medication adherence, and these vary from lab tests that can test whether or not a certain drug has metabolized into a patient's system, claims data, which I'm going to talk about more as an example, counting pills between visits. There's some technology that will count or automatically transmit some information every time a pill bottle gets opened, and then of course self-reporting. Those examples that I cited in terms of objective data are not easy. They usually require some degree of resource or technology, and then self-reporting is inconsistent. Whether that's the patient reporting directly to the provider or the provider trying to discern in an interview with a patient whether or not they're taking their meds. Oftentimes we get that wrong despite our best efforts. With regards to interpretation, medication adherence is not necessarily easily interpreted, and again, I'll talk about some examples and explore the challenges there. But as opposed to the traditional vital signs that I referenced at the start of this, adherence is measured over time. And also, adherence can vary depending on the drug. So generally, if we're measuring a patient's body temperature, we can all agree that they've got one temperature at a moment in time based on the reading. But with regards to medication adherence, there might be some drugs that a patient takes very consistently and others that they don't take at all. And so trying to come up with one number or one specific measurement is a challenge in this space. And I think we need to be mindful of the fact that if we try to oversimplify this, then it's not altogether actionable in the way that we would like for it to be. And then the actions to be taken are not always self-evident. There is some data out there that says if you just provide medication adherence information to physicians specifically, it's unclear what sort of effect that has with regards to outcomes or medication adherence overall. The literature is mixed. And again, like Mike mentioned, it is valuable to consider the roles that other people play in this. So it might not be just that we're providing information to an individual, but that we're providing the right information to the right individual who knows what to do in certain circumstances. Next slide. So the example I'm going to approach here is a claims-based approach, and this is one that our team has worked on. Advocate Healthcare has approximately 1 million lives that are attributed to it. So we receive claims information for not all of those patients, but for many of those patients, and that gives us the ability to look at when are patients filling their prescriptions, or at least I should say more specifically, when are they using insurance to fill their prescriptions, which is commonly the way that most people fill their prescriptions. You can see in this visual representation here that each dot represents when a fill is made or when a patient gets a prescription filled. The line following it would be when the time period for which they would have a sufficient dosage. So we make an assumption when we look at this that, oh, the patient's taking their meds regularly over time, which we know may not always be the case. And then if they, let's say they refill the prescription before it's done, what we'll do is put that next fill at the end of the previous fill, indicating, you know, for how much time did a patient have their meds. This is not a perfect approach, but for a system like Advocate or anybody else with access to claims information, it is an expedient approach, and we can infer some things from it. If a patient's routinely filling their medication, there's a good bet that they're taking it consistently. If they're not filling it at all, they're probably not taking their meds. There is a numerical translation of this, which is the percentage of days covered, or PDC. And that just tells you, as the name implies, you know, for what percentage of time, or what percentage of days did the patient have sufficient dosing. And generally, you'll see 80% used as a threshold. So if the patient has sufficient medication for 80% of a given time period, then we say, okay, they're highly adherent. Maybe not perfectly adherent, but they fall into that top group. Next slide, please. I'm going to show you a few examples, and these are real patients at Advocate. So this would be a patient who we would consider highly adherent. You see that we've separated the quartiles. So at the top would be a highly adherent quartile, and then with a PDC from 50 to 75, we would say a moderate, a patient who's moderately adherent, and then below 50, we would consider those two quartiles as low adherence. You'll also notice that each of the medications that are listed here have their own unique profile, but on balance, this patient would be considered highly adherent across all of those drugs. Next slide. So here are a couple additional patients, and here, you know, I talked earlier about the challenges of the fact that adherence patterns vary even within one patient across multiple drugs. So you see on the left, this patient, most drugs we would consider are you know, the patient is demonstrating high adherence. You'll notice a synchronized gap between those high adherence. So maybe the patient is getting them refilled all at the same time, and it's not exactly when we would expect. So there might be a little bit of gap or a little bit of inconsistency in terms of when the patient's taking those meds. Then you'll also notice one med at the bottom that's just hanging out by itself. Not quite sure what happened there, but it's clear that the patient's pattern of adherence was different for this particular drug, and generally we'll refer to that as an outlier. So we might describe this patient as highly adherent with one outlier. On the right, you see another patient with an interesting pattern, which you might consider perfect moderate adherence. You'll notice that many of the drugs are being taken precisely half the time that they should be taken. So we might start to imagine what might be driving that. Perhaps this is a cost issue for the patient, and the patient is splitting pills to stretch out that prescription. But again, when you start to see these patterns and see the variance within them, you can imagine that the actions that a caregiver might take would vary depending on the pattern that you see. Next slide. And two more examples. So on the left, we would consider this patient demonstrating consistent low adherence. A lot of things get filled once and then just kind of drop off. No clear fill pattern after that. On the right, we see a pattern that actually we see quite commonly. So I referenced earlier or described the patient who was highly adherent with one outlier. It's not uncommon to see patients who demonstrate this mixed pattern. So for some drugs, they're very consistent and demonstrating a pattern that we would consider highly adherent. And then at the bottom, or on the right, you see that the highly adherent drugs, and then at the bottom, those drugs for which they're demonstrating low adherence, very inconsistent fill patterns. And so I've introduced a few terms like high, moderate, low adherence, also mixed adherence, and some other descriptors like outliers or synchronized gaps that might help a caregiver understand what we're talking about. But hopefully, as you've looked at this, you can appreciate too that the visual representation of a patient's fill history tells a much richer story. And so rather than thinking about this as a vital sign in the classical sense, you might consider, you might liken this to some of the more visual information that we have in clinical settings like EKGs or imaging studies, things where a trained provider can interpret, and we do things to help that interpretation be as fast and consistent as possible. Next slide, please. I'm not going to get into all the nitty-gritty of this particular slide. This gives some general distribution information for the population of about 50,000 patients for whom we did an initial study. The thing that I would call your attention to is the fact that over a quarter, 26% of the patients in this study we would categorize as demonstrating mixed adherence. So when we think about our patients, we need to move past this notion of, okay, some patients are highly adherent and they take everything consistently, and some are low, demonstrate low adherence, and immediately we conjure up stereotypes of a patient who's, doing everything by the book and doing everything the doctor asks, and then other patients who just won't do anything that anybody asks of them. And the reality is it's a much more nuanced story, especially with regards to these mixed adherence patients, where there's something going on there. They're very consistent with some drugs, inconsistent with other drugs, and the approach needs to take that into account. Next slide, please. So yeah, in an effort to tie a bow around this before we go to questions, so what do we do with this, or what can we do with this? In general, the literature would indicate that using multiple approaches leads to the best results. Is that feasible? That probably depends on the healthcare provider. or whatever part of the industry you're connected with, and access to data, access to resources. So that's a consideration. Next consideration is we talked earlier about the importance of medication adherence, but it's also important to differentiate the fact that it's very important in certain circumstances and less important in other circumstances. So there would be certain clinical circumstances like a patient who's receiving HIV medication where adherence is very clinically relevant. Or think of patients with multiple chronic conditions where certain meds, those maintenance meds that are critical for their chronic conditions, would be different than one-off meds for less severe illnesses. And then the final consideration is that if we're driving towards standard definitions and interpretations, one of the challenges here will be access to data. I mentioned there are multiple ways to pull, to collect this medication adherence information. I showed one way, claims-based data, but that's not the only way. And where you're collecting this information, either through lab tests or pill bottle mechanisms or self-reporting, then you won't necessarily be able to replicate some of the things that I've shown here. So that's certainly a challenge to coming up with a unified approach, but we definitely agree that given the importance of medication adherence with regards to health outcomes, that it really is something that we need to be thinking seriously around, okay, how are we measuring that on a consistent basis? So I'm going to stop now and turn it over to questions.
Great. Thank you so much, Cam. And I just want to thank you for such a thoughtful presentation. I think one of the things that we discussed in these roundtables and with part of the collaborative is this really is not a simple answer. There's not one measure. There's not one vital sign. So I appreciate you kind of pointing out the subtlety here and the nuance in terms of thinking of medication adherence as a vital sign. One of the reasons that we're sharing this information with everyone today is the Electronic Medication Adherence Collaborative is an ongoing effort. We didn't just sit down and in 3 or 4 meetings figure out the solution to this problem. This is really, we wanted to share with you kind of the progress and where our thinking is at right now, and some of the really groundbreaking and thoughtful discussion we've been having. I think Tim and Mike have really helped kind of illustrate that for you in some of the examples they've presented in terms of where this discussion is going. This isn't an easy discussion. There isn't one answer. There isn't one vital sign that we can just use across the board. So I really appreciate your thoughtfulness there. I think, as Tim pointed out, the mixed pattern is really where most of us lie, somewhere in the middle. We're not always adherent or never adherent. I think people are somewhere in the middle usually, and it's a much more complex situation to try to figure out, how do we really address medication adherence? And Tim, I think your last point was really important. When does it matter? So I do want to kind of pick up on that a little bit. We've gotten a lot of questions, and I want to also ask for folks to submit their comments because, as I mentioned, this is a work in progress and we are continuing to meet. So we're very interested in your comments and thoughts in terms of where our discussion is going. This is a work in progress. So why don't we go ahead and go to some of the questions that have come up and see where that takes us. I did want to clarify up front, there were a lot of questions about FICO and the FICO score. FICO, for many of you, is just what it sounds like, the FICO credit score, which many of you get to determine how eligible you are for different credits. And FICO actually worked with researchers and CDC to come up with kind of a medication adherence score, so a similar type of score. And that's exactly what that is. A number of people had kind of asked about what that FICO means, and that's exactly what it means. The same company that does the FICO score has worked with researchers to try to determine a medication adherence score. So that's that piece. There was a question back, Mike, part of your presentation on slide 21. Claudia, I wonder if we can go back to that slide. Contributors to improving adherence. And there are a couple of different contributors listed there: physicians, caregivers, pharmacists, and health plans. So the question is kind of, Mike, what do you think about this approach? For patients who are managing conditions, and CBS research has learned that patients in peer-to-peer social networks can also kind of play a role in the social adherence and have an important role to play here. So Mike, I'm just kind of interested in your thoughts, and Rick and Tim as well, what peer-to-peer healthcare, if that might help boost adherence.
Well, we kind of focus on the caregiver. From a Medicare standpoint, there's a lot of privacy concerns related to that. But, if there's a way that we could, solicit, those, if we can kind of navigate through those types of issues, I think that makes a lot of sense, because obviously, if you've got people working, peers that are encouraging you to stay on top of your medication, I think that can have a powerful impact. Caregivers is the closest thing that we are able to actually utilize, and that seems to be an effective way. So I think it's similar but different.
Rick?
Yeah, so Jen, just a quick comment. Accenture's done some work with an innovation group at MIT, and there's actually been a book that's been written on the impact social networks can have just on behavior change. So if you think about adherence from a behavioral perspective, it makes perfect sense. Don't think that we've done enough in that area in healthcare, although we're starting to drive certain kinds of discussions around diseases and sharing information on best way to treat and manage diseases. We haven't necessarily zeroed in on medication adherence, but I think it makes complete sense, and there has been a fair amount of work on the effect of peers or like-minded individuals that are dealing with a similar situation to help drive behavior change.
Tim, any comments?
No, I would echo what's been talked about. We're, from an advocate standpoint, we're keenly aware of the fact that our reflexive approach has been, a doctor saying, well, you really need to take your medication. And I think that if it's not well documented, we all intuitively know is not necessarily going to change a patient's behavior. We're looking deeper into the relationships that our providers have with patients, recognizing that the quality of that relationship may affect how they respond to advice or counsel that they're receiving from their provider. We're just scratching the surface of peer-to-peer stuff. Certainly, from the standpoint of a healthcare provider, you work with the tools that you've got. And so we're starting with our provider network, but we know that the story doesn't end there, and this is a little bit uncharted territory for us. So it's on our radar, but we're not sure how we go or where we're going next on that.
Actually, there is another question here for you, Tim, regarding Advocate, and that's that PDC and other claims-based data do not address primary non-adherence, which is a key problem. Does Advocate have a way to identify primary non-fillers?
Yes and no. That's a great question. Another one that's on our radar. We're doing a couple things here. One is we did a temporary partnership with a major pharmaceutical, a major pharmacy to see about primary medication non-adherence for Advocate attributed patients. Surprisingly for us, at least, it didn't yield the same amount of opportunity that we were expecting, but we still know this is certainly an issue. The patient who gets prescribed something and never fills it. So the other piece of this is marrying our claims information with our EMR ordering information. So if we're capturing when something's being ordered and marrying that to fill patterns, then that can expose some blind spots where, hey, this is ordered for a patient, but they never filled that. And we've got some of the technical infrastructure in place for that, but not all of it. So that remains a work in progress.
Great. There is a question about surveillance and how can you make scalable behavioral changes among patients between provider visits and refills? And I do want to just point out, we had a lot of discussion about this. We were really lucky to have researchers from Johns Hopkins MedAdherence Center and also from Rush who've done some really exciting work around kind of studying why are reasons that people don't take their medicine. I think we touched on that. Mike touched on those a little bit in his slides. This is certainly a much deeper discussion that we can't have all of that today. There is some of that information available in the report. I think Kaylee sent out the link there. So you can see kind of some of the buckets in terms of behavioral changes that can be addressed in between provider visits and refills. So I just want to target people and point you in that direction there. Mike, I don't know if you wanted to make any kind of general thoughts about behavioral changes related to adherence and anything that maybe United's doing or that you've seen.
Well, it's all about reinforcing and engaging with our member, like I said in the presentation, that it just takes constant reinforcement. A member that's on 30-day refills has 11 points of failure throughout the year, and when they get their refills, in between refills, they may have any one of those barriers that I outlined in regards to forgetfulness or just anything along the line that could prevent them from getting their refill. So what we have is analytics in place that identifies our membership that we really need to keep an eye on and focus on with our initiatives and engage with them, as well as really expand the multi-channel engagement process so that it's not just a phone call, that we have tools available for our physicians, for frontline pharmacists, so that we can engage with those patients that need it. And on the flip side, we want to make sure that we're not harassing our members, so that those members that are adhering and staying with their medical therapy, that we're not needlessly calling them and negatively impacting them about their overall impression of our product that we provide to them. So we do want to balance the number of outreaches, but also we want to continue to re-engage with those members that truly do need it.
Great. There was a question about different disease groups and who we're going to be targeting in the Medication Adherence Collaborative. I will let you know for the next upcoming meeting, next quarter, we're going to actually be looking at cardiac patients and cardiology medications. And so that's kind of the next group and next thing that we're going to think about a little bit. That doesn't mean we're not looking at other groups, but that's going to be one of the focuses of the next meeting that we have. So I do want to answer that question there. The technology, what influence does technology play in patient medication adherence? For example, does Cerner provide providers who write prescriptions the ability to track their own panel of patients and those patients' adherence based on the meds prescribed? So Cerner or Advocate, Tim, what are you seeing in that area? What do you guys do?
Yeah. Let me see. So if the question's focused on written prescriptions, there isn't too much, to my knowledge, that Cerner has created in that place. Certainly, we have more robust data around any sort of e-prescribing activity. And then obviously the example that I gave was based on claims data, so that's showing it on the back end. But to my knowledge, I'm not too aware of anything that Cerner's put in place with regards to written prescriptions and giving a provider the ability to track that directly.
Mm-hmm. Okay. Great. There's a question about claims data, and that claims data is really great for what is going on, but how are you using this data to build interventions on understanding why? And do we have an example of an intervention that is working? I'm just going to open that up to all three of you guys. Does anybody have, I know there are lots of examples we've heard about, but Rick or Mike, do you guys have a good example we could share with the group?
Yeah, this is Mike. Just give a second. I'm hearing some background. For our initiatives, we rely heavily on claim activity, and with that, we have very timely, access to claims, practically on a daily basis. And with that, we, are using that information or lack thereof to identify if patients are getting their refills on time. We had a engagement act. We continue to have an engagement activity where we reach out to members, and with that, some patients are not upfront. They may not, give you the whole truth, if you will, in regards to if you ask them if they're taking their medications. They may just say yes. We have, an activity that's going on where we proactively have this information accessible to a clinician that is working directly with the patient, and can basically, identify that up front and be more proactive. In other instances, we've also had phone calls that have been made to our patients, and it's easy to hide behind a phone call and say that you've already picked up your medications, but when you have a pharmacist on the other end of the line that can actually see the real-time claim activity and mention to the patient that, no, it doesn't look like you have had a claim, the patient has kind of taken a about face on that. And in one instance, the patient would actually say, well, no, I didn't get my medication. I'll go get that today. And we can actually review that later in the afternoon to confirm that they actually got it, and close out our engagement activity on that particular example, if that makes sense.
Mm-hmm. Great example. Rick, did you want to add anything?
Yeah, I would only add that the claims data is a reasonable data source, as Tim was describing, to help generate a profile for intervention with the patient. I think the key as we move forward is to create the profile for the individual. And in order to address one of the other questions on the surveillance earlier, I think you have to understand the risks. This goes to the FICO score or vital sign. What's the risk that individual adhering to their medications, which can be indicative, which, other data can really point to the risk for that individual. So I can see the actual fill patterns from the claims data, but I should be bringing in other data on that individual to really create the risk profile, and then understand what's the best way to potentially intervene with that individual. Some individuals only want to be talking with someone live on the phone, which a UnitedHealthcare can do. Others are very happy to be doing things online and working with data and tools online to help understand their medications, how to take their medications, when to take their medications, what the side effects might be, et cetera. And you can do all of that using technology, and claims is just one piece of that. So we're starting to work with actually, some of the pharmaceutical manufacturers to look at more comprehensive end-to-end medication adherence programs. And the claims data will just be one data source. Other data from the internet, other data from fill data, as an example, which is available from different sources on a more real-time basis, can help us to drive a better understanding of how to intervene and when to intervene with that individual. But you have to look at it from an end-to-end perspective and have some type of patient engagement platform to help track those engagement or interactions and understand the impact.
Great. So we have a question. What is the one resolution to all of these findings? And I don't know that we have one resolution to all of the findings here. part of the reason we have the Electronic Medication Adherence Collaborative is because we've determined that we really need to work together, all the different stakeholder groups, to try to determine the best path forward. So I do want to encourage you, and as I said and keep saying, this is really just, you know, step one of this journey in terms of figuring out how to work together and resolve many of these issues. And now that we have so much data, it's more critical than ever, I think, that we approach this as a multi-stakeholder group. So I'm really delighted that we've been able to share this information with you today. We're really just kind of the tip of the iceberg right now in terms of these questions and answers, and I'm very encouraged to hear all the discussion today and questions. Very interested in any individuals out there who are interested in joining our work. I encourage you, go ahead and send us through the chat or shoot us an email if you're interested and would like to join our next collaborative working session. We want to get as many different folks involved in this. If you have specific research that you'd like to share in this area, we want to hear it. Any ideas about how we can improve what we're looking at and discussing, we want to hear it. So I encourage you to get involved. We will be having another one of these sessions to share the work that we've continued to accumulate as we move forward. So please join us for the next one, and we hope to hear from you in the meantime. I do want to encourage you also to please upload any case studies or research or survey data or anything that you've got to our resource center. There's a medication adherence section, and we are very anxious for you to share and disseminate work that you've done in your own areas. I do want to thank again Cerner, UnitedHealthcare, and ConnectiveRX for helping to support this webinar today and support some of this work. And I want to thank Rick and Mike and Tim for sharing their thoughts and research today. We couldn't do it without you guys. We are going to be working, as I mentioned, we'll have another announcement soon regarding the next meeting. We'll be working also, Tony Schuth is going to be joining us from Point of Care Partners to help facilitate one of the next sessions when we meet. So I'm excited to announce that today as well. And I look forward to the ongoing discussion. So Rick, Mike, Tim, thank you for joining us. And thanks to everybody here for joining us today. Have a great afternoon.
Thank you.